Good afternoon, everybody. Welcome to Grand Rounds today. It's my pleasure to introduce Dr. Jeffrey Varnell. Dr. Varnell is a surgeon and a risk management consultant for COPIC. He has kindly accepted our invitation to present today, and you can see the title of his talk. It's conceivably, possibly, maybe not, all clear, is your patient ready for surgery? A little bit different format today. Tim has allowed us, we're hopeful to have somewhat of an interactive format, so Tim has allowed everybody to have the ability to turn their camera and microphone on. So if you want to interact, you have that capability. And without further ado, we'll get started, and please join me in welcoming Dr. Varnell.
Thanks, Dr. Hallberg. And I thank you all for attending. As he said, we'd love to have your responses and input as we go through the discussion. As always, of course, we'll leave time for questions afterward as well. So today we're talking about preparing our patients for surgery. And we're dealing with an historical issue which in the past, when patients were preparing, particularly for a large elective surgery, they would be referred to be cleared for surgery to either a primary care physician or a specialist, or sometimes the surgeons would do it themselves. But in looking at it, we've come to a new understanding that perhaps that's not an all or nothing phenomenon as that implies. So our goal here is really to reduce the risk of complications that patients have when they go through surgery. Now, we look at it really from two ways. One, of course, is if there is an allegation of negligence after a complication, how do we decide whether to defend it or not? But also we want to know ourselves that we've done everything we can to reduce the risk of those complications for our patients. No one will have a 0% complication rate. So it's on our behalf to go ahead and do what we can to reduce those risks. So we kind of look at 5 elements when we're doing that, both from the defense side and from knowing that we've done the most that we could. And of course, it starts with the informed consent process. We want to make sure we have appropriate indications for doing the surgery. Today we'll be talking about the third, which was, did we take all the known preoperative measures that we can to reduce the risk? And then finally, we look at technical performance, and then whether, if there is a complication, if there was an early recognition and rescue of that complication for the patient. So we're focusing on number 3 today. So as we've said, can we actually clear a patient for surgery? And as I said, that kind of leads to a binary understanding, whereas I think what our real goal is what processes and what risks can we identify preoperatively, and what can we do to mitigate those before the patient undergoes surgery. And it's becoming more of a science and a specialty now. There's perioperative specialty societies and people that focus on that, and I'm sure in your hospital and community that's being done to some extent. So we're going to look at some of those areas where we can actually intervene. I'd like to start off with several cases that will illustrate what happens when we don't do those things ahead of time. And then we'll move to some of the things where it's harder to identify actual direct complications, but that have been clearly shown to reduce risks of particular complications going forward. So our first case is a 56-year-old man who presented to his primary care physician because of swelling in his legs. He underwent some evaluations, including ultrasound of his legs, cardiac examination, but they weren't able to find a diagnosis, and then concerned about the possibility of thrombosis in the iliac veins, they did a CT scan of the abdomen. And sure enough, what that showed was the patient had a kidney carcinoma. So He was sent to the urologist, who recommended that he have a nephrectomy. And prior to the surgery, he sent him back to his primary care physician to be evaluated. The patient had a history of hypertension and also diabetes on oral hypoglycemics. He noted that his wife noted that he had sometimes snored, but he'd never been officially worked up for OSA, obstructive sleep apnea. The patient was taken to surgery, and the surgery went well. They were able to do a nephrectomy through the laparoscope. On the first night of surgery, the patient was back in his room on the floor. His nurse happened to come in early on and noticed that his oxygen was off, so she put it back on, and after she did a pulse ox, which showed that his pulse oximetry dropped to 84 without the oxygen. So she put it on, and it came back up fine, and she made a note in the chart. The next day, the patient was seen by a resident who noted that and said it was important to continue to keep the patient on oxygen. They started the discharge planning. It was hoped that the patient could go home the following day, in 2 days. The next day, or that day, the patient did well. However, at 9 o'clock that night, the nurse came back into his room, and he was snoring loudly. So the nurse said, well, I don't want to wake him up. I didn't want to bother him to take a pulse oximetry. So she just left. 3 hours later, the nurse came back in the room. Unfortunately, the patient was found unresponsive. They tried to resuscitate him, but unfortunately were unsuccessful. So the patient passed. They did an autopsy, and what do you think the autopsy showed? Does anyone have any suggestions? I'd love to hear what you think caused this man to pass. Anybody want to hazard a guess? I'm hearing some microphones kind of go on and off. But to move forward, so obviously one of the concerns was, did he have a pulmonary embolus, which did not show up on the autopsy? Did he have an MI? And that didn't show any sign of that either. It did, however, show that he had an enlarged right heart. And so ultimately, the diagnosis was able to be made that he had an arrhythmia, probably secondary to obstructive sleep apnea, which, as I said, he'd never actually been worked up for that. And they did not employ a screening technique in the hospital to determine if that was the case. So that led, unfortunately, to his demise, which could have been prevented with several measures. So certainly for patients with obstructive sleep apnea, we like to make sure that we use appropriate pain medication. If they've been diagnosed and they have a mask that they use at home, that they can bring that in and use it. Probably they would be recommended to have more close monitoring, either in the intensive care unit or with permanent remote pulse oximetry. And as I said, you can change the pain delivery so that they don't have to rely on on-demand and mix it with sleeping medications. So in the long run, we end up having to settle this case because the opportunity to make the diagnosis of obstructive sleep apnea and change how he was managed after the case was lost. So let's move on to our next case. This is a 58-year-old woman who was undergoing an elective right knee replacement. She had a history of DVT on the left side. She had been managed with Coumadin in the past, warfarin, but had been weaned off of that in the past. So the plan was is that she was going to start on Lovenox preoperatively, and then use that when she went home as well. And again, this was before the availability of the newer oral agents, but they were planning on doing that. So she underwent the surgery, her knee replacement. Everything went fine. She was on the Lovenox in the hospital on the third postoperative day, which was a Saturday. It was felt that she could go home. So on Friday night, the surgeon wrote in the chart that they would be sending her home on Lovenox. The next morning, his PA saw the patient and discharged the patient. The patient went home. Unfortunately, 3 days later, her husband found her in the morning, and again, she had unfortunately passed. This time, the autopsy did show that she had a large pulmonary embolus, which they were confounded with because she was supposed to be on the Lovenox. But it turned out that the surgeon had assumed that the PA was going to write the prescription, and the PA assumed that the surgeon had already given the prescription to the patient. And so the opportunity was lost, and she did not receive any of the Lovenox when she was discharged home. So there, a failure of communication in an attempt to reduce her risk of pulmonary embolus and DVT led to that lost opportunity. So communication and lack of systems to screen people are the first two things that we've seen here. Next case is a 28-year-old woman who has a history of recurrent episodes of pericarditis and strep throat. She's been treated on several occasions as an adult. After she'd been having several bouts of this, her physician recommended that she consider tonsillectomy. So she was referred to the ENT physician. The ENT physician recommended that she have tonsillectomy. That seemed to be appropriate. So the patient was brought to the ambulatory surgery facility, and plans were made to perform the tonsillectomy. The patient underwent the surgery successfully. Postoperatively, the physician surgeon wrote for a prescription for oxycodone for the patient to take home. Just as she was about to be discharged, she asked the circulating nurse, I have some pain medicine at home. Is it all right if I go ahead and use that? And the circulating nurse said, well, let me check with the anesthesiologist. And the anesthesiologist said, sure, she can take it if she has something at home. So the patient went home. Unfortunately, again, during the night, she had an apneic episode. Her boyfriend found her, but called 911, but he was unable to resuscitate her, and she ended up passing. So what do you think the cause of death was? When they did the autopsy, what do you think they found? Does anyone want to try to guess what actually happened in this case? Sounds like the audio isn't coming through. So what happened was when they actually found the patient and took her to the emergency room trying to resuscitate her, what they found was that she had fentanyl patches on her body. And it turns out that, the patient had been using fentanyl patches in the past. She had managed to wean herself off of them 6 months prior to her surgery. No one had asked her about her previous drug use. And so when she went home from the hospital, she actually took the fentanyl patches as well as took the oral pain medications that they had prescribed her. And of course, since she was, after 6 months, basically not tolerant to the fentanyl doses that she was used to before she weaned off, she was much more sensitive and then had basically an overdose that was accidental as a result of that. So I think it's really important to have plans for how you're going to manage patients' pain after surgery, and to have to take into account what their own history and comorbidities are. And for patients that are on chronic pain medication, then you need to make sure that you work with whoever's prescribing those, that you have a consistent plan as to how you're going to manage their pain, during and after their surgery. And there's a lot of things that obviously can be done, but the first step is recognizing that there's a risk here, and then also communicating among the team how that's going to be done. So in this case, there wasn't any communication between the surgeon, the anesthesiologist, the circulating nurse as to what the patient was taking, what she had at home, and the opportunity again was lost. Okay, so this is a case where a patient presented to his gastroenterologist at age 38. He had a history of rectal bleeding. They did a colonoscopy, and the patient was found to have a sessile polyp. It was biopsied and found to show carcinoma in situ. The patient, the gastroenterologist, marked the area with India ink so it could be found afterwards. The patient was referred to a surgeon for surgical resection. The surgeon felt that since this was carcinoma in situ, they could probably do just a local excision on the anti-mesenteric border. So the patient was prepped. The surgeon went in. He saw the India ink and removed that area, and was successful in sewing the colon back together. The pathologist noted that he could not find any cancer in the specimen. He told the surgeon, who said, well, perhaps then when the GI doctor did the biopsy, he removed the whole thing and there wasn't anything left. So he recommended the patient have a scope again in a year to make sure that that polyp had been removed and there weren't any other polyps. Unfortunately, the patient was lost to follow-up. 3 years later, she presented with right upper quadrant pain, and unfortunately what she had was metastatic carcinoma of the colon to the liver. When this was reviewed later on after the patient had passed, what had happened was that the gastroenterologist had marked the area across from where the polyp actually was, as opposed to directly into it, because he was afraid if it bled, it would wash the marker off. But there was no communication between the surgeon and the gastroenterologist, so the surgeon just removed the area that was marked. There was no communication between the pathologist and the gastroenterologist and the surgeon about the absence of finding cancer. And there was no method for tracking the patient to come back to the hospital or to the office for another colonoscopy a year later. So absent a tracking system, the patient didn't come back, and they didn't send her a reminder notice that she should come back. All these were opportunities that were lost. So there was communication failure, system failure, and certainly the surgeon did not closely review the report of the gastroenterologist to note where the lesion had been marked. So another opportunity lost there in that situation due to communication. So those are some of the stories that we can hear where it's unfortunate, the outcome. So let's look now at some of the opportunities of what we can do in addition to the things that we have started to do, but somehow aren't actually accomplished. So we've all had a challenge working with patients to get them to quit smoking. It's daunting. It can be very difficult to have them actually succeed at that. Anyone have any idea how long a patient needs to quit smoking in order for them to achieve a benefit if they undergo surgery? Anybody want to try? Some of you, I'm sure, are more experienced at this than I am.
1 month.
Yeah, a month, even 2 weeks, they start to see a benefit, but it continues to increase up to 1 month prior to surgery. So even if you can get them to quit for that short period of time, it's worth the effort. And so, you know, however it takes, and again, we're primarily talking about elective surgeries today, so where we have the opportunity to intervene. So certainly it's one of those situations where, you know, if we can delay it even for 2 weeks or a month, and the patient's able to stop smoking for at least that period of time, that reduces their risk of pulmonary complications afterwards. So that's one thing that you can work closely with the patient and reap the benefits of if they're able to do that, even if it's not on a permanent basis. And who knows, after the surgery, many of them may be able to maintain that abstinence from smoking. So nutritional screening is another opportunity that we have. I can say that we've never seen a lawsuit for a patient that says that they weren't adequately prepared nutritionally before their surgery and they had a complication. Sometimes it's hard to draw that line, but we do know that patients that have adequate nutrition when they undergo particularly larger surgeries have a reduced rate of many different types of complications. So the healing is certainly much better, whether you're talking about, you know, an orthopedic bone fusion or healing of anastomoses in the abdomen or recovery from pelvic surgery, either urologic or gynecologic. All these have been shown that you can improve recovery, the likelihood of recovery by adequate nutrition. So what are the best ways to determine if a patient's nutrition is compromised preoperatively? Anybody have any processes that they follow? So certainly there are certain blood tests that have been shown to be useful. So albumin, prealbumin, transferrin, those are all good examples of ways of determining how the patient's nutrition is overall. Certainly you want to check on some of the micronutrients such as magnesium and calcium to make sure that there is no sign of malnutrition from that perspective as well. You know, certainly you want to look at weight and where we talked about, you know, quitting smoking. Also, for some patients, being able to lose weight prior to their surgery is really important. For some patients, for example, they have bariatric surgery, that's a requirement. And, you know, patients that are obese are actually at increased risk for being malnourished because in many cases, the calories they take they have are you know, don't or lead to, you know, malnutrition from a balance standpoint. So anybody have any other suggestions for at-risk patients for being malnourished besides the overweight? Well, certainly patients that are elderly are at increased risk. We've seen that. Patients that have mental conditions that are living by themselves. So there's a number of things that you can identify where you can actually justify doing a nutrition screening and having them work with a nutritionist prior to major surgery, again, to improve their likelihood of getting through the surgery without complications. This isn't necessarily something we do on every patient, but if it's going to be a major surgery in many different specialties, it's worth doing that. So, as I said at the beginning, this is one area that has been standardized, you know, across many systems. So, you're probably familiar with this term ERAS, which basically means enhanced recovery after surgery. Is there a clinic or someone running a preoperative clinic at your hospital? So it sounds like people are trying to say something, but we're not always receiving it, unfortunately. At least I'm not hearing it. So this can be done by a number of different specialties, and it kind of varies according to the local community. So another technical term for it is perioperative surgical home. So this is basically a clinic that you can refer your patients to prior to surgery, where these things have all been standardized. Sometimes they're run by hospitalists, sometimes by anesthesiologists. A number of different specialties can, prepare this and, create, the fast tracks for various specialties and types of surgery that, are common in your community. It's a valuable thing because it takes the burden off of, the surgeons and sometimes the primary care physicians in order to make sure that everything is done and nothing kind of falls through the cracks, because currently there's a lot of things that we can do to improve our patient's ability to, make it through surgery without, complications or delayed recovery. So let's kind of look at what that would look like from that perspective. So this is a bit of a complicated slide with a lot of information, but you can see that there's opportunities in many different arenas and time periods around in the perioperative period that, where we can intervene. So certainly with preoperative care, we engage the patients, assess and triage what their concerns are. This is where we perform the various surgery or screening procedures, whether it's for DVT risk and how we're going to prophylax obstructive sleep apnea, cardiac conditions, if they have diabetes, who's going to manage that? Are they at risk for postoperative dementia or anxiety, et cetera? What are the protocols that are available to help us get through that? And then who would be best able to manage that? And then obviously now there's several things we can do intraoperatively as well. And again, you have to recruit all the specialties to get involved with this. So that would include not only the surgeon, but the anesthesiologist, the nursing team involved with the care, the hospitalists that might be seeing the patient pre and or post-operatively, and make sure that everybody's on board with the approaches that are going to be taken. Clearly, there's post-operative things as well, how we're going to manage the pain afterwards. Is there going to be a pain management team, or who's going to decide as to what would be the best pain management for this particular patient? And then also the long-term recovery, which a lot of times has to do with evaluating the conditions under which the patient will be discharged home, what they can expect when they get home. As you can see, it takes several, quote, microsystems, they call it in this, and all the way from human resources, nursing, pharmacy, lab and radiology, IT, social services, as well as the physician specialties that will be involved as well. So it does take an effort to put this together, but in the long run, once all the protocols have been put into place, this makes it a lot easier to make sure that everything gets done and we don't have certain things fall through the cracks, such as what we saw with the failure of DVT prophylaxis in that patient, or the failure of pain management in the other patient. So at the preoperative area, just to look at, again, the earlier you give the patient education, the better, so that they're not, at a time of anxiety, right preoperatively or postoperatively, so that they know what to expect. For GI surgeries, if a bowel prep is indicated, that could be done appropriately. We've actually changed, for example, for GI surgeries, how we manage the bowel, even in cases when you're doing anastomoses. So, we're used to the old MPO after midnight thing, even if your surgery was, 2 in the afternoon. So now we know that it's safe to start to be able to feed the patient up until, a few hours before surgery. So if we want to maintain their nutrition, we can give them Ensure up to 7 hours. They can have Gatorade even up to 3 hours before surgery, which reduces the likelihood of dehydration during surgery. And the whole idea of they come in dehydrated, and then we have to flood them with fluids during the surgery, and then we have to diurese them after the surgery to maintain that fluid status. And then obviously there are things we could do from postoperative pain management as well. So you start off early on with possibly acetaminophen or pregabalin prior to the surgery, so that they have a kind of a head start on that, and it reduces a likely need for opioids in the postoperative period. So, for example, in a preoperative total joint situation, it's important to see what the home resources are for the patient. Are they going to have stairs, or are they at risk for falling? Make sure they have transportation, make sure their cognitive status wouldn't require an additional help there. Make sure that they're strong enough. Again, that's part nutrition, but also we want to make sure that they build up their muscle strength prior to the surgery, so that they can do an appropriate rehab after the surgery. And then some patients, obviously, if they're going to have their best experience, if they can lose weight before, for example, a total joint or whatever, the likelihood of getting through it is much better. Again, intraoperatively, we've obviously come a long ways in terms of pain management, rather than just, writing a prescription for oxycodone afterward and using pain pumps, in the postoperative period. Now there's much more liberal use of epidurals. We want to consider if on-cue pumps, for example, would be useful in the immediate postoperative period. During surgery, lidocaine can be helpful intravenously. We want to make sure that we address possible risks of vomiting after surgery. So several different things could be done concomitantly, even if they don't have a history of postoperative nausea. Again, more pain medicine, the ketorolac is possible. We want to be sure that we try to minimize, the risk of over infusions of fluid. And obviously, we still want to maintain normothermia and normocapnia, and there too during the surgery, the time that they're in the OR. And finally, in the postoperative period, again, we're much more liberal in terms of when we start to feed patients. We can, in many cases, we can give Ensure right postoperatively, encourage them to chew gum, which can reduce their risk of postoperative nausea, get them going the same day as surgery, out of bed, continue with the non-opioid opportunities for pain medication, get them off their IV fluids as quickly as possible, and also removing NG tubes much more quickly than we used to, even if we need them. Because in many cases now we don't need NG tubes even for complex intestinal surgeries. So at this point, I think it's time that we can kind of look at all this and see how we can put it all together. So certainly we continue to do the cardiac. So, the clearing for surgery used to be, a chest x-ray, an EKG, and some blood work. We still need to do a good cardiac evaluation of a patient. And again, it's not an all or nothing. You can have surgery, you can't, but what can we do to reduce the risk of your cardiac problems? There's a number of screening things that we can do as well. We talked about the importance of screening for obstructive sleep apnea, DVT? How are they nutritionally? Is this a situation where we can, intervene early on? Certainly from a pain management perspective, it's possible now to do many surgeries without having to use opioids at all when the patient goes home. So again, part of that is starting with an expectation for patients, what you're going to do afterwards. I know of several protocols where even total joint replacements, they're not using oral opioids when the patient goes home. Many of even the intestinal surgeries, abdominal surgeries, particularly when they're done laparoscopically, we can avoid using opioids. We talked about the smoking and the opportunity, even if it's for a short period of time, to get the patient off and reduce their risk of pulmonary complications, and also his risk of non-healing situations. You've seen in many of the cases that we talked about that communication is a very important part of avoiding these complications. And that's, communicating between the surgeon and whoever's doing the preoperative evaluation of the patient, communication with the patient and their family as to what their expectations on going home, communication with the other specialties, including pathology and radiology. Again, failure to rescue is a major concern as well, communication can among the specialties can reduce if there's a delayed recognition of a complication. We continue to want to be on the same page as to medication management, certainly for management of their diabetes. We're seeing more protocols now for bridging patients. More patients are on anticoagulants, and we want to make sure that we're clear about how we're going to bridge them if we are. Sometimes we can just stop their anticoagulant and restart it after the surgery. Other times, it's important that we have a protocol for how we're going to bridge them. And the surgeon and either the hematologist or internist or hospitalist is going to be involved with that have to be on the same page so that they know who's going to be directing that, how they're going to monitor the patient when they can get back to their usual anticoagulant regimen. And finally, for discharge planning. So that should start really even before, on a major surgery, before the patient goes home. So we're aware of the circumstances that they'll be returning to where they live. Do they need to go to a rehab facility first? Who's going to be able to assist them? What's their transportation availability? All these things need to be looked at so that we can, reduce the risk of their having a complication. And certainly our goal is not only to, if the patient does have a complication, which patients still will, but, can we defend it? But more importantly, have we done everything we could, given the current technology and availability that we have, to reduce that risk as much as possible by going through these things for these elective surgeries to make sure that the patients have their best chance to recover without any problems. So that's what I had to discuss. I'm sorry that we seem to be having problems with our communication in terms of your ability to tell me how things are going, but I think now we can throw it out for questions or comments. I'd be really curious as to what resources you already have in your hospital for doing a preoperative evaluation.
Go ahead and unmute or type in the chat box to put in your comments. Thanks.
Gee, should I exit this so I can see the possible chats?
Yeah, go ahead and unshare your screen and we'll be able to see you, and then you can click on the chat box.
Okay. There we go. Okay, so I'm sorry I couldn't see the chat box during. I appreciated your input while I was talking, but I didn't have availability to see it while that was going on. So, anybody want to share what resources you already have in your community? Do you have a preoperative clinic? Or failing that, how much, or what questions do you have that we could discuss? Okay, thanks. Dr. Hallberg says that, we typically don't have one. That might be something you want to look at, but certainly if you are being asked as a PCP or a hospitalist, there are a list of things that you can do, which, we've looked at some of them. But there are specialty societies, and there's a lot of literature on it now that can help you put that together. It would probably take a multidisciplinary team at the hospital to start the process. But I think in the long run, you'll find it's beneficial not only to the patients, but to surgeons and anybody else that might be tasked with, evaluating patients before their surgeries. Are there any questions by anybody? Tim, I hope I'm not missing them because I don't see anything here.
I'm not seeing anything either.
Okay. Well, absent that, I thank you all for attending. Hope you have a wonderful and safe afternoon. And I'm happy to answer questions if they come up later on. Again, my email is simply jvarnell@copic.com, and we'd love to hear from you. And I hope to see you sometime in person where I can actually see your faces and we can have more of an interaction. So I appreciate your attendance and have a great day.